Hi, my name is Kimberly LeBlanc, and I'm the Academic Chair for Nurses Specialized in Wound, Ostomy, and Continence Canada. And I'm joining you today from Ottawa, Canada. I wish I could be with all of you in Abu Dhabi, and I hope that you have a great Congress. Today I'm going to talk to you about peristomal skin complications. Should you have any questions at the end of this presentation, you can feel free to email me at chair@wocinstitute.ca. So here are my faculty disclosures. So at the end of this session, I really want to give you kind of a high-level overview of some of the common peristomal skin complications and to really differentiate between some of the different types. This is a picture of where I live. This is beautiful Ottawa, Canada. I invite all of you to come and visit us. Just be warned, it is a little cold. So what are peristomal skin complications? Well, peristomal skin complications represent a common and reoccurring issue for those living with an ostomy. And surprisingly, it's been reported that almost 80% of individuals will suffer from some type of a PSC within the first 2 years following the stoma creation. And we know that PSCs are heightened among those who are obese or living with impaired mobility. So peristomal skin complications, what are they? They're skin inflammation, injury, or damage that occurs within 3 to 4 inches from the stoma and or skin which is covered by the adhesive portion of the pouching system with the barrier and the adhesive tape or immediately outside of the skin barrier. Sadly, we don't have a great consensus concerning what stomal and peristomal skin complications are. So this makes it very difficult for us to have comparisons, benchmarking, and prevalence data. So there's many different types of common skin complications. So we're going to start with medical adhesive related peristomal skin injury, or PMARSI. And so if you can see here, there's different types, subtypes of medical adhesive related skin injuries related to the stoma. So we have mechanical, which is our skin stripping, just that outer layer of the epidermis is removed. We have tension injury or blister and a skin tear. And if we look at dermatitis, we can either have an irritant contact dermatitis, which is an inflammation of the skin that's caused from exposure to adhesives, fluids, corrosive bowel effluent, versus allergic dermatitis, which is an inflammation of the skin that's caused from an allergic reaction to the products being used. We can also have peristomal maceration or folliculitis, which is a inflammation of the hair follicles. So why is PMARSI an ongoing problem? Well, part of the issue is that there's this attitude that we find among caregivers and patients, which is, well, what else could I do? We should expect this kind of damage. We should just remove them quickly as possible, just remove the adhesives, rip them off, or there's absolutely nothing we can be done. And too often what I see with my patients is they're telling me, well, I guess I just have to live with it. And they're surprised when I tell them, no, you actually don't have to live with this. And when we see attitudes among healthcare professionals, often we're finding that it's lack of knowledge. So the ostomy appliance aren't being applied properly or removed properly. That there's a lack of belief that there's a difference between appliances, and that they're really not a prevalent problem. Now, we also have medical device related pressure injuries. And normally when it comes to an ostomy, what we see are pressure injuries related to either the abdominal support belts or hernia belts, as is the case that you can see in this photo is a combination actually between a convex appliance being put on someone with a hernia, but as well they had a hernia belt on top, and the hernia belt itself, the opening was too large. So we had really a double problem. We had a convex flange where we didn't need a convex flange, and we had an ill-fitting support garment. Now, we often see problems as well with things like pyogenic granulomas. So these are red papules that occur at the mucocutaneous junction, but as you can see here, they can often grow up around the stoma as well. The tissue is very friable and bleeds very easily. And, normally what happens is we see people who they just keep cutting their pouches larger and larger to accommodate. And unfortunately, this makes it worse. And the number one cause is actually persistent or recurrent leakage or seepage of the stoma output on the skin. So as you're going to find, actually with all of these peristomal skin complications I'm talking about, the majority of them can be prevented and managed by getting a good seal. So I encourage you, if you're not a stoma care nurse and you've got a problem with your patient, is to go and get a stoma care nurse involved so that they can assist you in getting a good fit for your patient. Crystal formation, this we find when we have constant exposure to urine. So normally we get these granules, it feels like sand, that occur on the stoma and the peristomal skin. They can be painful. The top layer can peel away and you get this denuded surface. And so normally it's really confined to the circumference of the stoma where the leakage kind of rests. So once again, the treatment for this is getting a good tight seal, getting a good fit. In some cases, we do need to do topical acetic acid soaks to help prevent or help reduce the growth. Hyperplasia occurs, and this is from constant exposure to urine or stool. So the effluent, it almost causes like a callus formation around the stoma. And once again, the treatment for this is prevention, which is making sure you have a good fit. And then we have the pseudoverrucous lesions. This results from chronic exposure of moisture or urine. So you get the crystal buildup in combination with repeated maceration. And so you'll get hyperplasia as well. And so you'll almost get these wart-like lesions that occur around the mucocutaneous junction, and they can actually really start to come in around the stoma. In the picture you're looking at, this is a woman that unfortunately finances were an issue for her, and she used to wear her same appliance for at least a month at a time, and she would hold it in place with duct tape. There are lots of leakage and issues and exposure to chronic urine, and unfortunately in her case she had to have her stoma recited. Candidata is another big problem that we often see, and this is really exposure to moisture. It can be from chronic leakages and moisture trapped under the flange. We often will see it as well in warmer temperatures where we have sweat that becomes a problem as well when the temperature outdoors is very hot and people are perspiring a lot. Pyoderma gangrenosum. Now, pyoderma gangrenosum is usually seen in combination with autoimmune disease. So as a stoma care nurse, I will see it frequently among my patients who have Crohn's disease. We will, or ulcerative colitis, rheumatoid arthritis. We'll often see that they will develop pyoderma gangrenosum. Now, it doesn't have to be with an autoimmune disease, but normally we see the two in combination. And normally when we see it around the stoma, it's a red flag for us that there's something going on systemically. So here we have these purpley, these really highly friable, very painful, inflamed wounds. They normally start as nodules or pustules. And then what will happen is they'll get these rolled purple looking edges, very, very painful. From the peristomal region, they're not behaving like a normal ulcer, and they don't respond to usual treatment, and they're not occurring due to leakage of the appliance or pressure. So we need to this really drives home that we need to look at the whole patient, and we need to make sure that we're really treating the whole patient and looking holistically to make sure we're looking at all their comorbidities and involving the interdisciplinary team to make sure that we're getting the systemic treatment they need and the proper diagnosis. Now, sadly, sometimes as well, we will see peristomal cancer lesions. They're often, they can be skin cancers, but often they can be metastatic as well. And this is where we need to really know our patients, know if they do develop peristomal skin issues, and we know that we know that it's not due to leakage, it's not due to pressure. We haven't figured out what the actual cause is. This is where we need to work with the interdisciplinary team to make sure that we're getting that proper diagnosis. Now, another issue that we'll see is psoriasis. So we'll see this in up to 11% of individuals with Crohn's and almost 6% of those with ulcerative colitis. They will also have an issue with psoriasis. So it's really important that we recognize what psoriasis is. I always work with my dermatology colleagues to make sure that we're looking at the systemic and topical treatment that we need to ensure that we're getting a good pouching system, but as well that the patient psoriasis is under control. And luckily there are topical steroid scalp preparations for when people have psoriasis on their scalp that we can actually use around peristomally, and they will not interfere with pouching. Fistulas can occur, and we know that 5 to 10% of those living with an ileostomy due to Crohn's will develop a peristomal fistula. So in this case here, you can see the small little, looks like a dent next to the stoma. This is a fairly easy fistula to manage in that we can encompass it into the actual pouching system. Quite often, unfortunately, that's not the case, and the pouching can become a real problem. Portal hypertension, this is seen normally it's in individuals with advanced liver cirrhosis, and they develop portal hypertension. Now, bleeding from this peristomal varices is rare, but it can happen. And it's really important that should you see this, that you recognize it for what it is, work with your the interprofessional team, and know that if bleeding does occur, getting it under control can be quite difficult, and you may need to send your patient to the emergency department, but you certainly need to collaborate with your with the interprofessional team to make sure you have the right diagnosis, because this is a symptom of a much greater problem. So what we've done is just basically giving you the Coles Notes version, very much a quick overview of peristomal skin complications. I invite you, if you're interested in stoma care and you want to learn more about peristomal lesions, that you visit the World Council of Interstomal Therapists. They have a lot of great resources. They also have a list of all the educational programs that they accredit globally. Also, you can visit Nurses Specialized in Wound, Ostomy, and Continence Canada. We have a lot of free educational opportunities as well as publications that you can access to learn more about managing peristomal skin complications. In May of this year, we're having our national conference. We invite all of you to check it out, come learn more about wound, ostomy, and continence. Here's my additional references. Please feel free to contact me should you have any questions. I really hope you have a great rest of your Congress.